Hi everyone. Although my clinical experience unfortunately got cut short, I still wanted to do an in-service for you guys to show you how much I really appreciated everything that you've done for me over the past 10 weeks. I hope you enjoy this in-service, although unconventional, and if you stick around till the end, there might even be a joke or two. Stay safe, and I hope to see you guys when this is all over. My in-service is on Alzheimer's disease and memory care strategies. I tried to make this the brief version because I know you are all very busy people. The objectives are to discuss the physiological changes to the aging brain, describe the global deterioration scale, understand patient presentations at different levels of the GDS, and to explore memory care strategies and incorporate them into treatment sessions. Alzheimer's disease is one type of dementia that is irreversible. It's a progressive neurodegenerative disorder which damages the cerebral cortex and subcortical areas of the brain, and there is a decrease in the neurotransmitter acetylcholine. Outside the cell, there is an overproduction and under-removal of beta amyloid, which creates an amyloid plaque that sticks to the cell membrane. Now it can't conduct properly, resulting in an accumulation of beta amyloid outside the cell. Normally, inside the cell, there are small microtubules and tau protein that helps to keep the axon straight and supported. However, in Alzheimer's, the tau protein is misshapen and it won't conduct information, which results in neurofibrillary tangles. The Global Deterioration Scale is the most commonly used scale to divide dementia and Alzheimer's stages based on cognitive decline. There are 7 stages. People in stages 1 to 3 don't typically exhibit enough symptoms for a dementia diagnosis. By the time a diagnosis has been made, the person is typically in stage 4 or farther along. This scale also helps physicians determine the best treatment approach and aids communication between health providers and caregivers. The brain goes through normal changes as we get older. Your brain is fully formed by the age you are 25 years old, and it starts to decline around 40 years old. The GDS stage 1 is when there is no cognitive decline. This person is experiencing normal aging, not dementia. He or she is independent in mobility and self-care as long as there are no other comorbidities preventing independence, and is going about their normal business. They may even be traveling, although not right now. GDS stage 2 is known as very mild cognitive decline. This is normal forgetfulness. For example, forgetting names or where familiar objects were left. Symptoms of dementia aren't often evident to the individual's loved ones or physician at this time. GDS stage 3 is mild cognitive decline. This patient is experiencing a reduction in perceptual awareness and surroundings. They have difficulty concentrating and could have been in a car accident. They have poor judgment and they cannot handle complex tasks. Daily routine is very important for success at this stage, and the average duration of this stage is approximately 2 to 7 years. GDS stage 4 is moderate cognitive decline, which is when there is decreased short-term memory, and the physician can detect clear cognitive problems at this stage. It might be difficult for the patient to travel alone to new places. They might start withdrawing from family or friends because socialization becomes difficult, and they are typically in denial about their symptoms. This lasts for about 2 years. GDS stage 5 is moderately severe cognitive decline and lasts 1.5 years. There are major memory deficiencies at this stage. The patient will require assistance with ADLs, and they may not remember their address, phone number, time of day, or where they are. GDS stage 6 is severe cognitive decline. This patient is at high risk for falling, and they are disoriented to time and situation and will experience personality and emotional changes. They are often impulsive with reduced awareness, anxiety, and agitation. They can remember some details of their early life, but they often forget names of those close family members. They are generally able to obtain procedural memories. For example, if you lay out their clothing, they'll most likely be able to put it on, but they might not be able to initiate the clothing process. And they are also incontinent. GDS stage 7 is very severe cognitive decline, and it lasts about 1.5 to 2.5 years. This patient essentially has no ability to speak or communicate. They require assistance for all mobility and transfers, and they are dependent for all ADLs. Memory is broken up into declarative and non-declarative. Declarative is our explicit memory, which is comprised of semantic memory, facts that we remember, and episodic memory, remembering personal events. Non-declarative memory is our implicit memory or how-to knowledge, like how to ride a bike, brush our teeth, or go for a walk. The strategies that we are going to talk about are aimed at improving the implicit memories. The Montessori method is used to find engaging and meaningful tasks for the patient. It focuses on the strengths and abilities of those with dementia. By incorporating activities that the patient was once interested in, he or she is more likely to actively participate in therapy. For example, a patient who used to play basketball. In order to work on standing balance, posture, and strength, have them shoot a ball into the makeshift basket. This way they stay engaged and you're also incorporating therapy. Spaced retrieval is performed in order to help people with cognitive deficits retain information by using the procedural memory. Possible treatment targets include safe transfers, recalling the names of caregivers, strategies for swallowing, or memory aids, such as calendars and schedules. You want to start with 1 or 2 targets because you don't want to overwhelm the patient, and you can achieve better results. For better results, it's important to choose functional and personal memory targets. Now, this won't cure memory loss, but it can help to improve a patient's independence and reach their therapy goals. It can also be used with people with Parkinson's disease, traumatic brain injury, and aphasia. For spaced retrieval, you want to first choose a functional target or goal. Then, you will ask a question to elicit the target response. If the answer is unknown or wrong, tell the patient or show the patient the right answer, and then have him or her repeat it back. Then you want to ask again 15 seconds later. If the patient can't recall, give the answer and then have him or her repeat it back. Try again in 15 seconds. If it's still not right, spaced retrieval may be inappropriate for this patient. When the answer is given correctly, double the time interval, starting with 15 seconds, then 30 seconds, 1 minute, 2 minutes, 4 minutes, etc. And then ask the question again. Repeat this step each time the answer is correctly given. If the answer is wrong, give the right answer immediately and ask the question again at the last correct time. In between asking questions, you can fill the intervals with other therapy activities or conversation. Try to choose activities or topics that have little to do with the memory target. Let's take a transfer, for example. You would ask the patient, "Where do you place your hands before standing?" "On the armrests." And then repeat 15 seconds later. If the patient responds with, "I don't know," you would say, "Place your hands on the armrests." When the answer is given correctly, you would double the time interval each time by asking the question again. And if the answer is wrong, then give the right answer immediately. Errorless learning is a feed-forward instruction. The therapist will prevent patients from making mistakes. If incorrect responses are prevented and only correct ones are enabled through cueing, it can allow for better learning. For example, while performing a transfer, say place your hands on the armrests before standing up, or move the patient's hands to the armrest for them. With repetition, the hope is that this will become part of the patient's procedural memory, which they are capable of maintaining. The theory behind it is that when we make an error, it often becomes reinforced, making learning the correct way more difficult. It's hard to completely eliminate errors, so reducing the amount of errors a patient makes is ideal. Here are some ways to promote errorless learning. You can simplify tasks, use visual cueing and modeling the task before a patient performs it, encourage the patient through cueing to avoid guessing, and immediate correction of errors. When a patient masters the task in its simplified version and performs it without errors, the difficulty level can gradually be increased. Here are some helpful researched communication strategies to incorporate when treating patients with dementia. Approach the patient from the front. Due to their decreased processing time, allow up to 90 seconds to process commands. Use simple word commands. And smile, even if it feels exaggerated. When treating these patients, never argue, instead agree. Never reason, instead redirect. Never shame, instead distract. Never lecture, instead reassure. Never say remember, instead reminisce. Never said, "I already told you." Instead, repeat it. Never say "you can't." Instead, help them with what they can do. Never command or demand. Instead, ask or show. Never condescend. Instead, encourage. Never force. Instead, reinforce. I hope you can incorporate these strategies with your future patients who have cognitive impairments. Try not to forget these strategies, but if you do, you can refer to the handout that I've emailed to Rob. As promised, here are a couple of jokes. What do horses say when they fall? "Help, I've fallen and I can't giddy up." What do you call a bee that can't make up its mind? A maybe! Thank you. It has truly been an incredible clinical experience with you all. Thank you for your guidance, help, and the unforgettable memories. Stay safe.